This UCSD TV program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest programs.
Hi, everybody. I'm Dr. David Granite, and welcome to Health Matters. Everybody worries about this word that I'm going to say, and the word is cancer. There are a lot of new treatments, a lot of new approaches, but it still scares everyone. We're going to get through that. We're going to have an expert with us, Dr. Ezra Cohen, who is Associate Director of the Moores Cancer Center and a Professor of Medicine here at University of California, San Diego, to work through this topic. Welcome.
Thanks, Dave.
Now, you just finished your time as Editor-in-Chief of Oral Oncology, which is a very powerful, impactful journal in the field. You are one of the top experts, whether you get embarrassed about that saying it or not. You know, this is for the family to see that they know you're actually real. And one of the things that we wanted to talk about was some of the new approaches and new treatments for that word that no one likes to say, and that's cancer. Yeah. Take us through. Let's start with a couple of definitions. First off, what's cancer?
So cancer, we've come to realize, is really a genetic disease. It's a disease that's made up of alterations or changes in the normal DNA. So the DNA that's in every cell in our body acquires alterations, mostly mutations. Sometimes some genes get deleted, sometimes some genes get overexpressed multiple times. And for one reason or another, those changes confer an advantage to that cell or that clone. That also eliminates the normal signals that tell every cell in our body to either stop growing, sometimes to die, a process called apoptosis. And cancer cells have basically lost that normal physiologic functioning and signaling. And so they grow uncontrollably. Its basis is all genetic or some sort of change in the gene expression. But its phenotype, or what we see, is essentially uncontrolled growth. And that uncontrolled growth, unfortunately, leads to a dysfunction of critical organs like the lung or the brain or the liver, and then eventually death of the host.
I want to talk to you about treatment of cancer, and especially some of the new techniques for something called immunotherapy. But I don't think we can talk about immunotherapy without talking about what is the immune system.
Right. And so the human immune system, we have to realize, is a wonderfully engineered set of checks and balances. It's meant to essentially eliminate any pathogen that is a threat to the host. Now, it's really meant for infectious diseases, so bacteria, viruses, some fungi. The immune system doesn't do a great job there, but you know, it's okay. But essentially, that's what it's meant to do. It's meant to quickly identify something as being different, as being foreign, quickly eliminate it, and then shut itself off. And if you think about it, that's exactly what we want the system to do. We don't want the system to be on all the time because that will cause internal damage. That is autoimmune disease, rheumatoid arthritis, lupus, the list goes on and on, inflammatory bowel disease. If the system gets turned on too rigorously against normal tissue, that's bad. But we want it to be turned on against cancer. And
so we want the immune system to recognize cancer is not self, is different.
Right. And from what I just said to you, you can begin to understand why that might be difficult for the immune system, because cancer is a derivative of self. It's a derivative of normal cells.
Two people walk in a room, they kind of look alike. Which one is which?
Right.
And how do you know?
Exactly.
Or the usual suspects for the police trying to figure it out.
Right.
Now, I grew up in an era where the treatment of cancer was by chemotherapy. And I just remember in my head thinking that you're giving a toxic chemical and you're going to find out which survives, the cancer or the person. It just never felt like it was a great thing, but my goodness, it was a way to treat, and there's still a role for that.
Absolutely.
But you can obviously see there's some problems with chemotherapy.
Without a doubt. Chemotherapy is really designed to be toxic to cells that, most chemotherapies, toxic to cells that are dividing at a rapid pace. So at their essence, they are all DNA toxins. And so if you insert or introduce a toxin to the DNA in a cell that's rapidly dividing, that cell will die. That's the hope, that's the theory for cancer. The problem is that normal cells also divide. And so they are poisons. That's their very nature. But that's what we've had for decades, for the better part of the 20th century. That's what we had, that's all we had. And for many cancers, those drugs are effective. We have to realize that for leukemias, for testicular cancer, for other type of germ cell tumors, chemotherapy is curative, even for widely disseminated disease. So we're not ready to throw away chemotherapy, but your comment I would very much agree with. We are, and many of us feel that we are really at the precipice of a major change in the way we view cancer and in the way we treat cancer.
Years ago, the first person I met who was embarking on this field was Dr. Malcolm Mitchell. And Mal told me that when he first started using this kind of approach, he was castigated and chastised, and he would just say, "Please let me try," and it was considered heresy. And now you're saying we're on the precipice of a whole new approach.
Yeah.
How exciting that is.
It's I've been in oncology for 20 years, a little bit more. I don't think I've ever been as excited about the prospects for patients than I am right now.
How great! Those words are.
So this is there. In my opinion, there's no more exciting place to be. But what you said is absolutely true. That for decades, and you have to realize that the first successful immunotherapy for a cancer was in 1908. So, and that was essentially injection of dead bacteria into cancer patients to try and mount an immune response, obviously against the bacteria, but also against their cancer. And in a few patients, it actually was successful. That's called Cooley's toxin after the person who tried it. But that was over a century ago. And what we needed to do was we needed to learn more about the immune system and how it interacts with the host and how it interacts with cancer. And it took us a long time to learn that. And that's the unfortunate reality. But now we're at a point where we're beginning to see the fruits of that labor and beginning to understand what we can do to turn, what switches we need to turn on, what switches we need to turn off. How do we get the immune system to recognize a cancer when it already hasn't? How do we get the immune system, what cells are critical for the immune system to eliminate the cancer? When you and I probably went to medical school, we learned about lymphocytes. We learned about these cells that you could see under the microscope that were very blue, kind of small, a little bit bigger than a red blood cell, but that's all we learned.
Yes. Now
we know that there are literally dozens of different types of lymphocytes, each with slightly different functions. And so the amount that things have changed, the amount of knowledge that we've gained, we're finally able to harness in very positive ways.
So does this bring us to the category of biologics? Is that where this all fits?
Yeah, in a sense they are biologics because the drugs that we're talking about, and I'll call them drugs even though they may not necessarily appear to be prototypical, the drugs that we're talking about are mostly antibodies, they're cytokines, in some cases they're cells, and some of the most exciting work that's going on in immunotherapy is cell-based therapy, and we can talk more about that if there's interest. But yes, they're really, for the most part, biologics. Although many of the drugs are also small molecules that interfere with critical signaling cascades that are important to different immune cell functions and different immune phenotypes.
So let's talk about some of that. So you have, you talked about antibodies, you talked about cellular treatment, you talked about some of those smaller molecules. We didn't mention, but vaccines.
Sure.
So I'd like to touch on each of those, and at least conceptually to say to people where these might fit in and how they might fit in, and if you can take us through each of those.
Right. So probably the most earliest successful, widely successful immunotherapies were cytokines. This is a drug called interleukin-2, another drug called interferon, and they were used for some hematologic malignancies, but primarily for melanoma. And we've known for a long time that melanoma is an immunogenic cancer. For some reason, the immune system has responded to melanoma, and now, again, going fast-forwarding decades, we're beginning to understand why that is. But be that as it may, those were the first drugs. And in some patients with melanoma, and in some patients with renal cell cancer, kidney cancer is also quite immunogenic, we saw complete remissions. And those patients who had those complete responses usually had them for a very long period of time.
And these are people that would have died, essentially?
Oh, these are people with widely disseminated disease, yeah.
So complete remission in somebody with widely disseminated disease that would have died, that's
right.
Miraculous.
It's incredible. And so the proof of principle was there, that if you knew how to activate the immune system in the right individual, wonderful things could happen. At the same time as those cytokines were being developed and used, a group at the NIH led by Steve Rosenberg was working on cellular therapy. And their approach was quite simple. If they could take out a tumor, harvest the lymphocytes from that tumor, what we call tumor-infiltrating lymphocytes, or TILs, grow those lymphocytes outside of the person's body, and then reinfuse them, they would be able to essentially create an army of these lymphocytes that could attack the cancer and cure the disease.
So they were identifying the ones that were successfully attacking and trying to build them up.
In a sense, what they were really identifying were the cells that were within the tumor. So the theory was that some of them were successfully attacking, but clearly not all of them. And at that point, we didn't know that there were actually some T cells that were inhibiting the immune response. And there were some T cells that were doing just the opposite of what we wanted to do. But this was 20, 25 years ago, and we just didn't know. And so, but the point being that it worked in some people. And again, it had, and in fact, if you've read Steve Rosenberg's work, you're familiar with a couple of patients that are still alive today, 20 years later, that had widely metastatic melanoma. And so the proof of principle was there that if we could find a way to do this on a wider scale, that we could really begin to cure metastatic disease.
And then vaccines?
And so vaccines for active
kids
cancer,
get vaccines, right? I mean,
yeah, and that's the distinction. That's an important distinction to make. So vaccines as therapeutics have really not been very successful. Vaccines as preventions for cancer have been successwill, and so hepatitis B would be one example. Human papillomavirus. We will see the results of that in the generation that is now getting immunized. Unfortunately, just as an aside, the immunization rates in the United States are abysmal.
That's why I wanted you to say something about this.
There are countries that have universal vaccination programs, and you know, I hate to say it, but in 10 to 15 years, when we don't see cervical cancer and HPV-related cancers in those countries, the U.S. is going to regret not imposing a universal vaccination program, but that's another story. But preventive vaccines have been and will be successful at preventing cancer if we can create a vaccine that's successful at eliminating the inciting event. Therapeutically, they haven't been successful. And again, we have to understand why. Because vaccines do produce an immune response. I mean, that study after study that's been shown.
It seems like you could create a vaccine to the tumor, and then say to the immune system, have at it.
Right, right. And so that was the hopeful approach. The reality is that it's not so simple. And not only did we have to develop, have to understand what the immune system responded to in terms of the antigens or epitopes, we had to understand the best vaccine platforms and how to, without getting into it too much, as you can imagine, a system that's designed to be turned on and off very rapidly and very specifically has a lot of different signals that are required. And so we had to understand what's the best way to activate the antigen presenting cells that need to activate the cytotoxic T cells. And moreover, we also had to understand what's preventing those cytotoxic T cells. So the sharp end of the stick, as my colleague Steve Schoenberger likes to call them, what's preventing them from actually killing the cancer? And so we realized that a vaccine itself is not going to be sufficient for a person with disseminated disease. We need to couple that with the right adjuvants, with the right stimulators of T cells, and influence the tumor microenvironment in such a way that we could get now a response.
In the popular mindset, the sort of the magical idea of, I'll get a vaccine, I'll do this, it's a couple of words, and why can't they? You're describing some really hard science.
Oh, yeah.
You know, some significant financial commitments, time commitments, brilliance on the part of the researchers, labs that are going on, piling on each other's work.
Exactly.
The work you did as an editor, seeing all these articles coming in and people publishing and disseminating that information. This is really how medicine functions. It's not the oh, let's just try it and wouldn't it be great if. This is hard work.
This is, and it's unfortunately, it can be slow work. It takes a lot of effort, takes a lot of time. And, but the nice thing about immunotherapy, just to get back to what we were saying before, is we really are at an inflection point where all of this has been building up for so long, and now things are starting to happen very rapidly. And I can give you, some wonderful examples.
Love to hear that.
But just to get back to the vaccines for a second, the other component that I think is really important is that we have to realize, if we're going to develop a successful vaccine, that every person's cancer is different. Even if you take two people with breast cancer, those cancers are different. And so if you think about it, if we're going to, and I think this applies to all of immunotherapy, if we're going to develop successful vaccines to a patient's cancer, it really has to be based on their cancer, which means to us, and this is, we're very involved in this program, to us it means a personalized vaccine for every individual based on what their cancer is telling us. Their cancer is saying, hey, I'm expressing these genes that are completely novel, that your immune system has never seen. And we think we can take advantage of that and create these personalized
So the days of
vaccines.
saying you have breast cancer are going to eventually be over. It's going to be, this is your profile, this is what you, and identify truly personalized medicine.
Yeah.
There's not a physician I bring on this set that doesn't somehow get to personalized medicine. And I think, though, that this is about as personalized as it's ever going to get for people, is to identify it that way. The inflection point that you talked about, somebody has cancer, and they go to an oncologist, might be in private practice, might be in the community. Who has access to these new treatments? Who should get access? Who needs to say, I need to travel to a Morse Cancer Center? How do they know where to go?
Yeah, so for most cancers, and even for cancers where immunotherapies have been approved, the leading edge, the most promising therapies are still in clinical trials. And most of those clinical trials can only be accessed, unfortunately, at major cancer centers. And again, that's another discussion about, I think we need to fix that. But the reality is, for right now, most of those clinical trials you need to access at a cancer center. And certainly Moores actually has probably one of the most robust portfolios of cancer immunotherapy trials in the nation. So we're able, I think, to serve our patients very well in that regard. The other thing to...
I'm sorry, but if someone goes to start to get treatment, is there something they can do that would actually stop them from being part of a trial? Or they have to worry that they began a treatment that disqualifies them? I mean, do they need to start it more in the beginning?
Well,
what do you do?
So I'm a believer that when you have a disease like cancer, it's a good idea to get a second opinion, to ask questions exactly like that. Because although really I think we have clinical trials for almost any scenario, and you know that's part of our job. That's what we're supposed to do. And so for somebody who's had no treatment, we certainly have studies. For somebody who's had treatment A, we have studies specifically for cancers that are refractory to treatment A, and that's the way we built the program. But having said that, I truly think it's always a good idea, even if your cancer appears to be very straightforward, very common. I think it's a good idea because it's a life-threatening disease, and it usually brings up issues that maybe your treating physician hasn't thought about. And even patients that come to me and say, hey, should I get a second opinion? I always say yes. And here's a list of names that that are really good in the field.
If nothing else, it provides the patient confidence in the approach that they're going forward with.
Exactly.
And so you raised one thing, and I really want to talk about this: clinical trials. When does someone know that it's appropriate to be in a clinical trial, and when do you say the treatment we have is realistically pretty good? When do you take the risk and go in a trial where you may not get the therapy? And how do you decide that, and who should be deciding it, and how do you have those conversations?
It's a really complex issue, and we probably need another show to just talk about that. But let me try to summarize some points. So first of all, and maybe my thinking is a little bit polarized here. I think that every cancer patient is a candidate for a clinical trial and should be considering clinical trials, because even if you have early stage cancer that's going to be resected, there is still a lot that we can learn. So we should always be thinking about clinical trials. Availability, logistics, costs, et cetera, those are all impediments, but we should always be thinking about it. Even if the standard therapy is, and for all cancers, we've defined standard therapy, so even if the standard therapy is good, we can always make it better. And that's what clinical trials are striving to do. Certainly for patients who have exhausted standard therapy and are still in a condition to receive therapy, they should be looking for clinical trials. Because you have to understand that the only way that we move forward and actually get to a point where we can cure cancer is through experimentation.
But we don't want people to think they're being experimented on. They're still getting options that are generally the current standard versus a new trial.
And those are myths that we really need to move beyond, because the community has to realize that the days of the Tuskegee trials or those horrific events that happened almost a century ago are gone. It's not possible for that to happen. There are so many points in the system where the ethics and the science are considered that would never. I can confidently say.
How long does it take you to get a study approved here at UCSD through the IRB, our review board for ethics, and all the other?
It's at least 6 months.
Right.
It's at least 6 months.
Review and careful.
And at least 3 committees, not just individuals, 3 committees looking at the study.
None of this happens by accident.
Right. And so if a study gets to patients, it has to be ethically and scientifically rigorous. Moreover, there are now data that clearly demonstrate that patients on clinical trials do better.
Say it again, because that's so powerful.
And it's something that many patients don't realize. That patients on clinical trials actually have better outcomes as a whole. And even, by the way, if they're on the standard of care arm. And that might be because inherent in a clinical trial is a fair number of visits. You have a lot of people looking at you as a subject.
Compliance from the patient's standpoint.
Exactly. Supportive care, et cetera. And so we shouldn't be viewing clinical trials as a last ditch or a last hope effort. We should be viewing them really as our best chance to get the outcomes that we want.
I love it. And in the short time we have left, give us your view of the future. The future, according to Cohen, here it is. What do you want to usher in, and what do you want to see happen?
Yeah, I think what we're going to see, and this is the near term, this is over the next few years, I think what we're going to see is immunotherapy is going to be approved for almost every cancer that we know of in one form or another. We're going to begin to understand how to combine the agents and the therapies that we have available together and with more conventional therapy like radiation, chemotherapy, et cetera. That will do two things. One, we're going to get much better efficacy, much better outcomes, and I think we're going to, at the end of the day, reduce toxicity to the individual. I think we will see a day where, I know this sounds like science fiction, but where we will be able to engineer an individual's T cells to specifically fight their cancer. And believe it or not, that is happening right now. That's not 10 years, a generation from now, that's happening right now. And I think we will actually have vaccines that will prevent most cancers, not just selected ones that are virally mediated, but most cancers. And we're on the verge of all of those things.
It sounds like your future includes people not being scared when they hear the word cancer.
I have one quick story. I was boarding an airplane, this is a few months ago, and there was a family behind me. We were going to San Diego, so I started talking to them. It was a long wait. And they asked me, what I do. I said, I'm an oncologist. And there was a girl, she probably was about 6 or 7 years old. She said, what's an oncologist? And I want to be at a day where we don't even have to think about that, where oncologists don't exist because we don't have to worry about cancer.
I like your vision of the future. Thank you so much for sharing your passion, your obvious passion for this. I think all of us in society owe you a thank you for all the effort and the energy that you're putting into helping others and what you're doing. This is how it gets done, and your energy is making it happen, and all the other people at Morris Cancer Center. So thank you. We have to have you back on regularly because this field is exploding.
There's a lot to talk about. Thank you very much.
My pleasure. I hope everybody who's listening, Dr. Cohen was very clear. The future is exciting, and the future is actually happening as we speak. By participating in a clinical trial as a whole, people do better. This is important to know. And here at UCSD, we have the Morris Cancer Center, but there are other centers, obviously, across the United States and across the world that are also doing great work. It's where our advances come from. Pay attention. Knowledge is power. I'm Dr. David Granite, and we'll see you again next time right here on Health Matters.